Hi, guys. A couple of things that I wanted to touch upon today. I don't know why I'm sounding like a newscaster. I'm going to talk to you guys while I eat akara and fried fish. I mentioned it that I was going to order something so that I won't have to cook all the time. I hardly have time to do meal prep. I used to be able to do it before, but recently I don't. So I bought akara and fried fish. But anyway, something happened at work that I wanted to share. Like I've mentioned, I work in the emergency department. We do run codes a lot. In fact, this is the most codes I've been in since I started my nursing career. And I'm finding that I don't like it much. I wanted to do it when I got this job. I wanted to be like, those Grey's Anatomy people. You jump on patient and you're doing your CPR and they're pushing the gurney into the ER from the ambulance. Now that I'm in the ER, I'm finding that being in colds is not really my forte. But the reason I wanted to talk about this is because I did my nursing education in Nigeria. That's where I started my nursing education. And I don't ever remember us calling a rapid or calling a code when I did my training. I don't know about now. It may have changed, I hope. When I went into nursing school 2003 and I graduated 2007. Even during my classes, nursing school classes, I don't recall codes, calling rapid being something that was taught in school, in nursing school, nor was it even discussed when I started clinical practice. When I finished nursing school, I worked 1 year in Louvre. Maybe it's like an internship, but I think there's a different word we call it then. So I did that in Louvre. No code. In fact, I didn't even know what code status is or was. Nothing about full code. I mean, in a hindsight, I think all the patients we had were full codes. But I can't remember doing CPR, chest compressions in Loop. I don't recall that. And then I remember I took a BLS training. I think it was about like 3 days when I thought I wanted to be an offshore nurse, work in oil rig. So I did that, but I never used it because as soon as I took that class, I got the certification, the ID card. I started working with health insurance agencies. I'm all over the place. So when I finished my nursing school, I worked in Lutz for 1 year, different departments, obs and gynae, medical, surgical, pediatrics. And then when I finished my 1 year, I started working in private hospitals. So from private hospitals, I now went into health insurance. And that's what I was doing until I relocated to US. So during all those my experience in Nigeria, I didn't do CPR once. I was never in a code, whether rapid or code blue. Didn't do anything of that nature. I did not even know what it meant. Patient dying. Now that I think about it, can't even remember what we did or what I did. Maybe some of the other nurses that I worked with might know what they did, but me in Nigeria, then I cannot, for the life of me, remember what I did when I had a patient that was dying. But anyway, back to my code status. So I didn't know what it was in Nigeria, but I think it's something that we need to tell our people about the code status if they've not already started doing that, like full code, CPR, do not resuscitate, do not intubate, because this patient that we had, her code status was no CPR and do not intubate. So that means we cannot do chest compressions and they could not put a tube down her throat to help with respirations if she ever needed it. But we could do medical, we could use drugs to resuscitate. But anyway, so we had this patient and suddenly her health condition just went from good to bad to worse. Let me put it that way. Heart rate dropped, no more sinus rhythm, and before we knew it, she was down to sinus breathing, low heart rate below 40s, and then extreme breathing to 20s. We called family. Family was able to get there on time, and within like 5 minutes, she was almost going into a complete heart block. So while all this was happening, the doctor was talking to the family, and she asked the family, do you want your mom? Because at this point, the mom could no longer make a decision. She was incapacitated. She asked the family, your mom right now has a code status of no CPR and do not intubate. Do you want to leave it at that, or do you want to change it to full code That way we're able to do all necessary intervention to keep her alive. And she said yes, switch it to full coma. So when that happened, I began to think like it would be nice to educate family, especially my family back home. I don't know, Nigerians, if you're watching my YouTube channel, or Africans, any African country, to learn about this code status. It's really good for people to have an idea what it means. So we ended up intubating the patient and sending her to cath lab so she could get a cardiac catheterization done. So I'm saying this because even I have not told my parents anything about this, but it's something that I've always been thinking about that I should talk to them about so that they will know what they want done for them if ever the situation arises. Anyway, I wanted to just share that with you guys. That's about code. Another thing I didn't learn in Nigeria as a nurse was lab draw, getting starting an IV line and starting an IV, getting blood samples. I didn't practice that in my nursing school during my clinical practice. The first time I accessed an IV line was, I was working in a private hospital, and one of the doctors, because she was drawing blood samples, and I guess she saw the way I was looking at her. And then she asked me if I had ever done it. And I told her no. So she said I could practice on her if I wanted to. I was so afraid. So she told me where to see the tourniquet, and she pointed to me where to put the needle to get the IV. And it was a straight out needle, 22 gauge, like a syringe and a needle. That's how we were getting blood samples then. No butterflies, no cannulas. It was just straight up needle and syringe. So I got that. But after then, I didn't practice it again. When I was working in the private hospitals, we have lab technicians. So any lab work, they would go, especially when I was in pediatrics. If they needed lab drawn, the lab scientists would come in and get the blood sample. So we nurses didn't do it at all. Same thing in Lutz. They had lab technicians that did it. But now I have almost perfected the art of IV insertions and lab drawn. So almost, not perfect yet. And then another thing I didn't do in Nigeria was inserting catheterization, Foley catheter. I didn't do it at all, not for female patient, not for male patient in Nigeria until I came out here. Something else too, now that I'm talking about it, was knowing lab values or the significance of some of the lab results. I remember one of the pediatric hospitals I worked at, the doctor used to be frustrated with some of the nurses. Me, one of them. We had neonates that would come in with jaundice, bilirubin levels up to the sky, leading to yellowing of their sclera, their skin, even their urine will be so yellow that it will stain their diaper. I'm saying it so fluently now, but back then, I didn't know, or maybe I didn't know that I knew the answers to the questions that she was asking me. And sometimes she'll be asking us, what is the normal value? Like, what lab value are we looking at when a patient is jaundice? So I just wouldn't answer. She would be like, what lab values are you looking at? Are you should you be concerned with if we have a patient that needs phototherapy? Because we always do phototherapy for these kids. My lab value knowledge was just probably 0 to none then. Even the simplest one, hemoglobin. When do you need to do blood transfusion? Because that's another thing we do too. We used to do exchange blood transfusion for some of these kids. And then she'll be asking them, what is the lab value that you should be looking at when you're doing blood transfusion? H&H, I didn't know it's in Nigeria. So anyway, at some point I started to learn, but initially I didn't know a lot of stuff. One of my research projects that I did in nursing school was about transient ischemic attack. My grandma, my late maternal grandma that predicted I should be a nurse, had that. She was misdiagnosed twice when she had TIA, 2 times. One of the doctors even said she had, like it looks like she's having dementia or memory loss. Meanwhile, the woman my poor grandma had TIA and she lost her speech. I could remember then we'll be talking to her, she'll be smiling, but she won't be able to express her word. And the first time she had a TIA lasted maybe a few minutes or a couple of hours, but the second time was almost 24 hours before it cleared. And I think the second time it happened, I had done that my research project. So when my aunt told me that they said she had, I don't know what they told her she had. I said, no, it's probably a TIA. And then we went to get a second opinion, and lo and behold, it was a TIA that she had. So on the medical side, I have learned a great deal since coming to US practicing as a nurse that I would not have. Maybe I would have gotten around to learning them in Nigeria, but it probably would have taken me a longer time. And when I did nursing in Nigeria, the only other nursing aspect of nursing that was promoted in nursing school was becoming a midwife and psychiatric nursing. Those two, psychiatric, no, I can never. Midwife, not for me. I knew I was never going to specialize in either one of them. So anyway, I'm glad I came out here because I've really learned a whole lot more than I would have if I stayed in Nigeria. I hope my other fellow nurses get the opportunity to learn as much, and that the teaching process have changed so that they're teaching more or things that are more practical skills that nurses will be able to use. I mean, I was seeing a whole lot of stuff that I could, especially when it comes to being the physical aspect of nursing. When I came out here, it was easy. Dealing with patient and family for me, communicating with patient and family for me was smooth sailing because Nigerian family are always there. They sleep there. If you let them, they'll put mat on the floor and sleep there. So it's not even like we're calling them on the phone to come. If you pursue them, they'll just go and stand by the door of the ward and be waiting until once you just crack that door open, boom, all of them are in. So we were like, they were in our space. They were also helpful. They will do bed baths, they will clean their family, they will feed. The only thing that if you allow them, they will give them medication. Nigeria. But we also lacked a whole lot, like resources to work with. I could remember routes going without electricity the whole night. Even when they turn on the generator, you might have generator running in the OR, operation department, where they're having surgery. I don't know what they call it, but the OR like here. So when they turn on that generator at night, that's the only section that you will see electricity, because maybe they're having a surgical procedure, so they needed the electricity. But the rest of us in the units on the ward will have to use candles and lanterns to do whatever we have to do. But I'm hoping that it has improved a lot because we don't need it. I know my folks are in Nigeria. My dad recently had to see a doctor for some medical condition and he was well taken care of. But like they say in Nigeria, soup way sweet, na money killer. If you know, you know. Anyway, I wanted to share that with you guys. I'm now going to go and get ready for my night shift. Thank you for watching.